With this, I welcome Dr. Sriram, all the audience, and everyone who has joined us in person or online. My special thanks to Dr. Padma Priyadarshini, who is the director ICMR NIRT Chennai. When we approached her on the last moment because of one of our speaker has stepped out due to some technical reasons, and she was kind enough to recommended very strongly Dr. Sriram's name in the area of epidemiology of team.
So as Dr. Sachin has elaborated, even though this platform is for Malaria Elimination Research Alliance, as the name indicates, but we are very deeply interested in the infectious diseases, especially which are on public health importance, and TB also is targeted to be eliminated in 2025. And the important work which NIRT and especially Dr. Sriram is into, getting those burden numbers, which has been given a long gap. I remember reading it in MBBS and MD. The TB prevalence surveys were done long ago. And this study, I hope we can see some glimpses of the results, and today will be a milestone in the in the burden studies in India, especially for tuberculosis. And TB has a very central place in public health programs in India. So I'm especially looking forward to this lecture today, and it will be a treat for all the researchers in general, even if they are not associated with TB research per se, but interested in human health. Thank you for doing this for us, Dr. Sriram. And thank you to Director Dr. Padma Priya for this. I know she's extremely busy holding, two hats currently as BCRC Director also. So, I extend my gratitude once again to all. Thank you.
So with this, I request Dr. Sriram to start the talk, please.
Thank you, sir. First, I would like to thank the organizers for giving me an opportunity to speak on this topic. I would also like to thank our director for giving me an opportunity to speak on this topic. Today, I would be giving an overview on what are the barriers and facilitators to ending TB in India. So the contents would be giving a background on Mycobacterium tuberculosis, how it has evolved, and reservoirs, and what are the TB disease types and treatment challenges, and what are the risk factors, healthcare seeking behavior and its impacts on elimination, and also like the burden of TB in India, and how are the patients being missed, and what is the health system response, how it is facilitating the ending TB in India. Mycobacterium tuberculosis is a complex bacteria which is very difficult to fight. It has multiple types of bacilli. Mycobacterium tuberculosis is one of the major organisms which infect human beings. Apart from that, there are Mycobacterium bovis, Mycobacterium africanum. So they are resistant to cold, and they are very sensitive to heat, and they are strictly aerobic, and they are very slow dividing capacity. And they have a different type of bacteria called Mycobacterium non-tuberculous mycobacteria, which is atypical mycobacteria. These are the classifications of tuberculosis species. So here we could see that a group of bacteria called non-tuberculous mycobacteria, where they go rapidly. And there is a group of tuberculous mycobacteria which are slowly growing. Mycobacterium tuberculosis complex and Mycobacterium leprae are slow growing mycobacteria. And apart from that, there are many other species of M tuberculosis like Mycobacterium ulcerans, Mycobacterium avium complex. Coming to the genetic diversity, with the growing capacity to do genetic sequencing and whole genome sequencing, scientists have been able to understand how the Mycobacterium tuberculosis complex has evolved. And Mycobacterium can adapt to responses. This also has an influence on the development of TB vaccines, diagnostics, and new therapies. Here we could see that initially, to start with, Mycobacterium prototuberculosis was the first one to start with, and with further differentiation, it has been able to spread itself in various strain types, and it has been able to survive by adapting to various situations. So that is where we are classifying them as human adapted strains and animal adapted strains. Putting human adapted strains and animal adapted strains together, we call Mycobacterium tuberculosis complex. Which we need to understand is, as the evolves, there are certain characteristics of the Mycobacterium tuberculosis makes it difficult to handle, and which makes them survive in different environments. So we could see that on one side, the time lapsed from past thousands of years. And on the other side, we could see how the lipid evolution has happened, leading to change in the hydrophobicity. In the evolving from ancestral mycobacteria related to Mycobacterium and Mycobacterium kansisi, modern M. tuberculosis has become more hydrophobic by increasing the proportion of less polar lipids in the outer membrane. Such a change would enhance the capability for aerosol transmission, affecting the virulence and pathogenicity. So here we could see that as the Mycobacterium has evolved in different organisms and it has undergone various changes, the morphology has changed and evolved, and that has become more virulent, more transmissible, and more pathogenic. And this different nature should also be considered when we develop new vaccines and treatment regimens. Coming to the reservoirs for tuberculosis, we think that Mycobacterium tuberculosis is present only in human beings, but there are evidences which suggest that potential transmission routes for M. bovis and M. TB could happen through direct transmission and indirect transmission through environment. And indirect routes of cross-species TB transmission, importance of certain environmental features in maintaining the infection systems. Why should we understand these reservoirs? Because if we are able to control and handle the tuberculosis in the human beings, but if there are Mycobacterium tuberculosis present in the environment, in the wildlife, in the livestock, they pose a challenge for further transmission in future. So in order to see that the transmission is averted, we need to take care of the burden present in the wildlife, environment, and livestock also. Then only we would be able to move confidently in the elimination of tuberculosis. This slide gives an overview on the environmental mycobacterial reservoirs. So here we could see that various studies have been done in various mediums of environment like soil, river water, soil exposed to sunlight, and then dust from tuberculosis medical wards and walls of rooms of TB patients. So all these have been tested for the presence of Mycobacterium in guinea pig models, and they were cultured. And when they were able to do the culture, they were able to identify the presence of Mycobacterium tuberculosis. So if we are able to identify culture samples positive from the soil or river water, so that is an evidence for the presence of mycobacterial tuberculosis reservoirs in the environment. So we need to be careful to see that those reservoirs are also understood. They are also so they also studied the survival of Mycobacterium tuberculosis in these different meat how long to survive. So different studies have shown that the cultures were able to grow up from 3 months to 12 months. So which soil or in the environment for 3 months to 12 months, which is important for understanding the transmission dynamics of tuberculosis. So as we already discussed, mycobacterium is a very slow dividing bacilli. It takes around 16 to 24 hours to divide, and because of its slow and insidious nature, the clinical presentation takes time for presentation. There is a requirement of excess delayed healthcare physicians, and this leads to late diagnosis, and this is a situation of long period of transmission. So whenever there is more transmission, that leads to more burden of disease. Now this biology of Mycobacterium tuberculosis. Now once the bacilli is inhaled or exposed to a human being, what are the different spectrum of TB disease that could present? An individual is exposed to tuberculosis bacilli, it could show a response in terms of acquired immune response, lead to either elimination of Mycobacterium tuberculosis or the establishment of Mycobacterium tuberculosis infection in the human body. So once the Mycobacterium tuberculosis infection is established, there are 3 stages that could be described. One is the latent TB infection stage, where there is presence of immune response and there is no presence of symptoms or signs, and there is no diagnosis of Mycobacterium tuberculosis in the sputum smears. The next stage is subclinical TB disease, where there are possibilities of diagnosing the tuberculosis bacilli in the sputum samples or radiological examination, but patient do not present with any symptoms. So that is called subclinical TB disease. And the last stage is active TB disease, first with symptoms of cough, fever, loss of weight, loss of appetite. And he could also be able to be diagnosed with chest X-ray and sputum examination. And then here the table shows what are the different tests that could be used to diagnose different stages of the disease. So usually for diagnosing TB infection, we use tuberculin skin test or interferon gamma release assays. They would be positive, and culture would be negative in the latent TB infection. Whereas in the subclinical TB disease, the TST would be positive, IGRA would be positive, and cultures would be positive, but X-rays would also be positive. There is no symptoms. And because there is no symptoms, the patients would not be able to seek care, or they would not be able to take treatment. And that poses a risk of transmission. That is positive for culture, smear, or molecular test, and the TST and IGRA could also be positive. Whereas the treatment for subclinical TB disease and active TB diseases, treatment with antituberculosis drugs based on whether it is drug sensitive or drug resistant. So this figure shows the pathogenesis of infection. So here we could see that once a bacilli is exposed to an individual, it is inhaled by the alveolar macrophages, and the migration to the lymph nodes for T cell priming happens. And once the granuloma is formed, that is the characteristics of TB disease. So the granuloma, once it is formed, it could either sustain in a granulomatous stage, or it could break down and release the Mycobacterium tuberculosis into the circulation. So innate immune response is the outcome of the exposure to TB bacilli, and the outcome of innate immune response is the presence of human granuloma. And the human TB granuloma are composed of central mass of infected macrophages, stimulated macrophages that have differentiated into multinucleated giant cells or epithelioid cells, foamy macrophages loaded with lipid droplets, and recruited monocytes. And inner accumulation of cells becomes surrounded by lymphocytes, largely CD4 T cells, but also CD8 cells, B cells, and fibroblasts, which create a peripheral fibroblastic capsule. The classical feature of human TB granuloma is presence of necrotic caseous core that is thought to be secondary to cell lysis, and that results in a central hypoxic hostile environment, which further leads to cavities. And the adaptive immune response to MTB depends on the CD4 T cells and additional contribution from CD8 T cells. Th1 cells are the CD4 T cells that produce interferon gamma, interleukin 2, and TNF alpha, and are the primary effector T cells and protective immunity to TB. Th17 cells are CD4 plus T cells that produce IL-17 and play a role in memory response to TB and might be an important in the vaccine-mediated production. CD8 plus T cells contribute to protective immunity by production of cytokines, expression of cytotoxic granulolysin and granozymes. Now we would explain about the TB disease type. So we previously saw that when a person presents with TB symptoms, he could be undergoing examination for sputum. So if he is positive for sputum, then we call that as microbiologically confirmed TB. A presumptive TB patient with biological specimen positive for acid phos bacilli, or positive for Mycobacterium tuberculosis on culture, or positive for TB through quality assured rapid diagnostic molecular test. And clinically diagnosed TB case is defined as a presumptive TB patient who is not microbiologically confirmed but diagnosed with active TB by a clinician on the basis of X-ray, histopathology, or clinical signs, with a decision to treat the patient with a full course of anti-TB treatment. In children, this is based on the presence of abnormalities consistent with TB on radiography, history of exposure to a case, evidence of TB infection, and clinical findings suggestive of TB in the event of negative or unavailable microbiological results. Classification by anatomical site of disease: pulmonary tuberculosis is defined as any microbiologically confirmed or clinically diagnosed case of TB involving lung parenchyma or tracheobronchial tree. Extrapulmonary tuberculosis is defined as any microbiologically confirmed or clinically diagnosed case of TB involving organs other than lungs, like pleura, lymph nodes, intestine, genitourinary tract, joint and bones, meninges, etc. Miliary TB is classified as pulmonary TB because there are lesions in the lung, and miliary TB is disseminated throughout the body. A patient with both pulmonary and extrapulmonary TB should be classified as a case of pulmonary TB. Classification based on drug resistance. Monoresistance is a TB patient whose first-line anti-TB drug only. Polydrug resistant is a patient whose biological specimen is resistant to more than one first-line anti-TB drug other than both INH and rifampicin. Multi-drug resistant TB defined as a patient whose biological specimen is resistant to both isoniazid and rifampicin with or without resistant to other first-line drugs based on the results from the issued laboratory. Rifampicin-resistant TB is defined as resistant to rifampicin using phenotypic or genotypic methods with resistance to other anti-TB drugs excluding INH. Patients who have any rifampicin resistance should also be managed as if they are an MDR TB case. Extensively drug-resistant TB is defined as an MDR TB case whose biological specimen is additionally resistant to fluoroquinolones like ofloxacin, levofloxacin, or moxifloxacin, and a second-line injectable anti-TB drug like kanamycin, amikacin, or capreomycin from a quality-assured laboratory. These are the treatment regimens for drug-susceptible TB and drug-resistant TB, and these are given in the guidelines for programmatic management of drug-resistant TB in India. So based on the drug susceptibility pattern, the treatment regimens may vary. For drug-sensitive TB, it is usually 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, and 4 months of isoniazid, rifampicin, and ethambutol. And for H monoresistance or polydrug-resistant TB, 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. And for MDR or rifampicin resistant and XDR TB, so there are different categories based on the drug sensitivity. So shorter oral regimen containing bedaquiline. So that is 4 to 6 months of bedaquiline followed by 6 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. And shorter injectables like those who are not able to be provided with bedaquiline, they would be given moxifloxacin for 4 to 6 months, kanamycin, followed by amikacin and ethambutol. In the continuation phase, they will be given moxifloxacin, clofazimine, pyrazinamide, and ethambutol. And there is also oral longer MDR or XDR TB regimen, which is given for 18 to 20 months with levofloxacin and bedaquiline based regimen. And this is the follow-up recommended for the drug sensitive and drug resistant TB patients. So usually the follow-up is done monthly to monitor the clinical progression after the initiation of treatment. And they are monitored by smear at the end of IP and culture at scheduled time points. So this is the integrated diagnostic and treatment algorithm. All presumptive TB patients or key populations should be directly subjected to molecular test called nucleic acid amplification test. And similarly, all TB patients should also undergo nucleic acid amplification test under Universal Drug Susceptibility Program. And based on the nucleic acid amplification test, they can be classified as whether they are rifampicin resistant or rifampicin sensitive. Based on the rifampicin resistance, they could be recommended for second-line specimen tested at culture and DST lab, and the regimens could be designed. What is the basis of chemotherapy? The role of chemotherapy is to combine multiple drugs and achieve killing. So here there are two phases of chemotherapy. One is intensive phase, which is given during the initial part of the treatment, and continuation phase, which is given in the second part of the treatment. The objective of the intensive phase is to combine 4 drugs to achieve rapid killing of actively replicating bacillary population. This phase will eliminate naturally occurring drug-resistant mutants and prevent the further emergence of drug-resistant mutants. And the continuation phase, there are fewer drugs compared to the intensive phase, but they are given for a longer time and they will ensure elimination of persisters which are responsible for the relapses. So this is the description of different types of bacillary population. In a given lesion of TB, there are usually 4 different bacterial subpopulations, metabolic rates and their surrounding environment. The first one is extracellular rapidly multiplying bacilli. They can be acted upon by rifampicin, streptomycin, and ethambutol. And the second category is extracellular intermittently multiplying bacilli, and they can be acted on by rifampicin. The third category is intracellular and extracellular acidic environment slowly multiplying bacilli. They could be acted on by pyrazinamide. The last category which no drugs could act on or reach there. So that is the major challenge in the treatment of pulmonary tuberculosis. This diagram shows tuberculosis patient with different drugs and the MTB cell type susceptibility. So here we could see that there is a picture of lung with light gray color and black color shadows. The one with light gray is the growing MTB. One with the black color is non-growing MTB. So inside the mycobacterial we could see that two types of lesions which are projected out. One is intracellular MTB lesion, and the other one, the table we could see that the physiological conditions of intracellular MTB lesion and caseous lesion. So in the intracellular lesion, there is an acidic pH which is lipid in nature, and whereas in the caseous lesion there is a neutral pH and they have a hypoxic condition. And we could see that following the physiological condition, there are different regimens, and they had presented with the arrows showing upward and arrows showing downward. So the upward arrow shows that the drug penetrates readily into the lesion, and the downward arrow shows drug penetration into the lesion may be uneven or restricted. See that in the caseous lesion, there are only few drugs that could penetrate into the non-growing MTB lesion. Challenge, so it is difficult for the drug, moxifloxacin, pyrazinamide, linezolid could reach those sites, and though they are able to reach, their effect also could be vary. That is the major challenge in the current chemotherapy. Now, what are the other challenges or that is the pharmacokinetic of anti-TB drugs. The first column shows the drug names, the second one shows the dose of the drugs, and the next column shows the serum Cmax and the Tmax and the serum. Here we could see that though we are able to give rifampicin of 60 gram, the serum Cmax is 8.4 microgram per ml, and it is Tmax is achieved in 2 hours, and the serum T half is 2 to 3 hours. It means that a good amount of 600 milligram given is able to really small amount of Cmax, and it is only similarly for isoniazid 300 milligram we give, but the serum Cmax is only 6 microgram. And this also are affected various pharmacogenomic and host genomic factors. So here the major issue that we need to understand is because this needs a long period of time for treatment, 6 months sensitive TB and 9 to 12 months for drug resistant TB. So adherence is important nature which we need to understand. So that is where the combination drugs are given in the current NTP program to see that the adherence is improved, and also like there are newer strategies of drug delivery systems to optimize this pharmacokinetics so that the drugs could be released in a sustained manner and the drug concentration is sustained, so that the bacterial killing could happen in a faster rate and elimination could happen soon. Now we saw about what are the basics of TB in terms of the bacilli biological characteristics, the spectrum of disease, the type of disease, the treatment. Now we would see what is the global and Indian burden of TB. So this slide presents the global burden of TB. There are blue circles of increasing sizes. So here we could see that India is having the biggest circle. So they have around 20 lakh incident cases. And also we could see that majority of the circles are in the Southeast Asia countries and African region. So here we could see that 8 countries, they contribute to 68% of the global TB cases in 2021 and 80% of them in 30 high TB burden countries. And India is the highest contributor of TB burden globally. So understanding the TB situation and taking appropriate interventions in India would have a major impact on the global TB control. This slide explains the population attributable fractions for TB. So population attributable fractions are indicators which gives us direction. Where are the major factors that contribute to TB, and where can we invest more to reduce the TB burden? So here we could see that factors like HIV, malnutrition, diabetes, alcohol abuse, active smoking, and indoor air pollution are the important population attributable fractions for TB disease among the high burden countries. So here the second column shows the relative risk of active tuberculosis disease, and the third column shows the weighted prevalence of these risk factors, and the last column shows the population attributable fraction for TB. So here we could see that malnutrition is having 27% population attributable fraction for TB. So we could say that 27% of TB is attributed to malnutrition. So if we are able to intervene malnutrition and eliminate malnutrition, we could eliminate 27% of TB burden. And followed by that, indoor air pollution contributes to 26% of, and followed by that is active smoking, and then and alcohol abuse. And this could also vary from country to country depending upon the epidemiological factors. The TB epidemic is driven by HIV, so the attributable fraction for TB among African countries would be high for HIV, whereas the epidemic for TB in India is driven by malnutrition, followed by diabetes, smoking. So the attributable fraction for malnutrition, diabetes, and smoking could be higher in India. So this slide explains about the missing TB patients. On the x-axis, we could see the timelines, and on y-axis, we could see the millions of patients per year. The green is annually, and the black line shows the number of TB patients diagnosed and reported or not. So here we could see that around in 2020, 0.6 patients are estimated to be having TB disease, while only 6.4 million were notified to the global TB program. So there is a gap of around 4 million TB patients who are missing. So it is important to understand that these missing TB patients contribute to increased transmission, mortality. So it is very critical to close this gap of estimation versus notification, so that every patient who is having TB is diagnosed and start treatment. That will ensure that transmission is averted and mortality is reduced. Shows the universal health coverage, which is one of the SDG indicators. On the x-axis, we could see the health service coverage index from 0 to 100. On y-axis, we could see the percentage of all households in the population with catastrophic health expenditure. Countries like Thailand, China, higher coverage of health service, they have a lower percentage of household expenditure for catastrophic cost. Whereas countries like Central African Republic, Democratic of Congo, who have higher expenditure are due to low health service coverages. India is like they are able to provide 55%, and around 20% of the households expect to have a catastrophic health expenditure. So the point is that we need to increase the universal health coverage. Expenditure on TB or catastrophic cost or catastrophic health expenditure reduces. This slide shows the burden of in India. So National TB Prevalence Survey in India was done after decades in India. In between 1955 to 58, survey happened, and after that there were only subnational which happened at the district level, and in 2011 national survey at the state level happened, and after that this is the only survey which happened at a national level. This survey objective was to estimate the prevalence of tuberculosis at the national level. So here we could see that there are 20 state groups represented in the y-axis, and the x-axis shows the prevalence of all forms of TB among all age per lakh population. In India, for all forms of TB, 312 per lakh population. of 287 per lakh. And there are certain high burden states like Delhi, Haryana, Chhattisgarh, Rajasthan, Uttar Pradesh, where the prevalence ranges from 747 per lakh population to 322 in Tamil Nadu. And there are certain states which have low burden compared to the national prevalence of 312 in states like Kerala and Gujarat, where the prevalence is estimated to be 149 per lakh population to 137 per lakh population. So prevalence is a burden estimate that could tell what is the burden of TB in the current point in time for the period of 2019 to 2021. From this, we need to see how we are able to identify what is the gap in the current situation. So for that, we need to able to see what is the estimated burden of TB and what is the notified cases in India. The survey also informed us about the healthcare seeking behavior of the population. So among the population who were surveyed in the country, around 36% who had symptoms had sought care, and remaining 64% of the people who had symptoms did not sought care. And among those people who had sought care, 50% went to government facility and 50% went to private facility. And the reasons for not seeking care among those 64% of the population, they were mainly due to ignorance of symptoms, not recognized it as an illness, and they had self-treated and they could not afford to seek care. So this is an important indicator which we need to understand, because if the people who have symptoms do not seek care, they would be transmitting TB clinically. So that would also lead to mortality. So it is important for us to identify these patients early and put them on treatment. So this is the gap between estimates and notification in India. So here the red line, we could see that WHO estimated incident TB cases, and the orange line shows the incident cases notified in India. So here we could see that around 25.9 lakh cases are expected to be present in the country, while only 21 a gap of around lakh patients. So here we could see that the two significant causes of the gap could be cases presented with symptom but remain undiagnosed, or either they are diagnosed but not notified. So as I previously discussed, the gap in notification versus the estimated TB patients needs to be closed, so that every person who is having TB is diagnosed and put on treatment. So what are the risk factors for TB and its impact on elimination? So disease progression, and for controlling, it is important to move towards elimination. So this is a model for epidemiology of tuberculosis. There are certain factors which increase the risk of exposure. And once a person is exposed, there are certain factors which could increase the risk of latent TB infection, certain risk factors which could promote a person becoming infectious disease person. And depending upon the healthcare seeking behavior and various diagnostic and treatment approaches, they could either get cured or died. So in this sense, cascade of care for all forms of tuberculosis in India is, we could see that we could see the represented. So the first column shows the prevalent cases. So we expect around 27 lakh prevalent cases. Among them, only 72% are able to reach the TB diagnostic centers, and this is affected by the healthcare seeking behavior. And if a person is not able to recognize his symptoms and see healthcare worker and get diagnosed, and only if a person reaches a diagnostic facility, he would get diagnosed. Of those 72% of the patients who reach the diagnostic centers, only 60% were able to be diagnosed with TB. Previously discussed, there are different types of TB disease manifestation. It could be microbiologically confirmed, it could be subclinical, or it could be clinically diagnosed. And among people who are diagnosed with TB, only 53% are registered for treatment. So here also there is a pre-treatment loss to follow. And among those people who are registered for treatment, only 45% are able to complete the treatment. This is because of various factors like adherence to drugs, the side effects, the economic factors, and the occupational factors that could affect the compliance to treatment. And of those people who had completed treatment, only 39% were able to have a recurrence-free survival. When we say recurrence-free survival, a person who is getting cured should be able to continue without symptoms. If he is able to having symptoms and presence with TB disease, again, that is called recurrence. So in this cascade of care, of progression, there are certain losses. We need to strengthen all care to ensure that all the prevalent cases of TB are able to get diagnosis and all are able to be registered and all able to complete treatment. And in this process, when person is not able to go to a healthcare, that is called as passive case finding. If a patient goes to the health system and seeks care, that is called passive case finding. So because of the reason that majority of the population with symptom do not seek care, they are in a situation of leading to transmission. So that is why health system has framed a new strategy of active case finding, where the health system goes to the community or vulnerable population and screens them for TB and diagnose them early and put them on treatment. So in order to close the gap of prevalent cases to getting diagnosed, we need to have interventions of active case finding, intensified case finding to strengthen the diagnosis. And once the person is diagnosed, we should ensure that all are put on treatment on appropriate regimen. So for that, we need to have a stringent follow-up of the diagnosed patients. So this slide shows the different contributing factors that affect the cascade of care. So on the top, we could see that there could be certain patient-related delays, and there could be certain health system-related delays. And in health system also, there could be either a diagnostic delay or a treatment delay. And on the other side, we could see that what are the various demand side factors and system side factors. So what are the reasons for patient delay? Like as we previously saw in the healthcare seeking behavior, ignoring of symptoms, self-medication, lack of awareness, addiction, fear, socioeconomic conditions, and migration. So these are the factors which affect the patient seeking care. And once the patient seek care, certain inappropriate diagnosis, cross-referral issues, especially from informal providers, improper advising for relevant tests, delayed collection of reports of sputum microscopy. These are the factors that affect the diagnostic delay. And pre-diagnostic healthcare expenditure, physical access residing in a non-DMC or PHI area, visit to multiple healthcare providers, financial constraints, delay in getting the test done and collecting test results, refusal to get the test done. These are the diagnostic factors that affect the initiation of treatment. And in the treatment delay, that could be because of delay in treatment initiation or delay in treatment completion. So that could be affected by poor provider behavior, referral by diagnostic provider to another provider, delay in report symptomatic treatment to patients for long periods, and physical access to health facilities. So these are the factors that could affect the health system delay. So now it's important for us to strengthen these factors and improve these behaviors to strengthen the cascade of care. So to summarize, the barriers, underreporting and uncertain care of TB patients in private sector, reaching the unreached like slums, tribal, vulnerable population, drug-resistant TB and recurrent TB, comorbidities like HIV, diabetes, undernutrition, smoke, and poor healthcare seeking behavior, leading to delay in diagnosis. So these are the major barriers for ending in. Now, the facilitator should be the strategies for overcoming these barriers. So we should be able to improve the TB notification rate to ensure closing of the estimation and the notification gap, and then ensure that the mandatory notification from private sector and active TB case finding to reach the unreached, optimum utilization of CBNAT machines, expand universal drug susceptibility testing, Nikshay Poshan Yojana to every TB patient, 100% reporting through Nikshay, and collaboration with line ministries to tackle social determinants of TB and community participation for TB elimination. So these facilitators are detailedly explained in the National Strategic Plan. So the National Strategic Plan is the document which facilitates us how we should be able to end TB in India, and they have defined 4 strategies: detect, treat, prevent, and build. So detect strategy objective is to find all TB cases with an emphasis on reaching every TB patient in the private sector. And treat strategy is to ensure treatment of all cases with high quality of anti-TB drugs. And prevent strategy is to ensure the emergence of prevention of TB in the susceptible population and stop the catastrophic expenditure due to TB by all. And the build strategy ensures build and strengthen the supportive system, including enabling policies, empowered institution, and human resources. So in the detect strategy, so these are the various sub activities which are happening. The decentralization of TB screening to the level of Atmanirbhar Bharat health and wellness center levels. So this is happening at a grassroots level at a population of 5,000 people. So the decentralization of the program ensure accessibility and availability of services to the population, and scale up of molecular diagnostics of resistant TB, universal drug susceptibility testing, vulnerability mapping, and active case finding, and private sector engagement. So here we could see that the increase in the microscopy centers from 2014 to 2021 from 13,000 to 21,000, and rapid molecular tests from 119 to 3,164, and culture labs for drug resistance testing from 50 to 87. So the country is trying to expand its services by increasing the infrastructure, and also active case finding through mobile vans. They have also started introducing the handheld X-ray machines, which are more easy to carry to long distances. Engagement with the private sector through the partners. So the expansion of the support agency has increased from 48 cities to 300 plus cities in 2020. And also strategies to strengthen the case finding in public sector. So to strengthen the case finding in the passive, have already introduced chest X-ray as a frontline screening tool, and rapid molecular testing, and active approach to active case finding in vulnerable population, and leveraging outreach of the other healthcare programs through the health and wellness centers. And also intensified case finding in health facilities, like bidirectional screening for HIV, TB, diabetes, TB, and COVID and TB. To ensure strengthening of the case finding in the private sector, they have introduced the Schedule H1 implementation. The number of chemists registered in NICSHI has increased from 15,000 to 43,000 notifying TB cases, and the mandatory notification of TB has been issued by the Gazette notification in March 2018. And they had also issued provisions of penalization using and patient provider support agency through JEET and domestic have ensured 77% increase in the private sector notification from 3.8 lakhs in 2017 to 6.8 lakh in 2018. All strategy is the treat strategy. So here we had moved from the previously used intermittent regimen to daily regimen, shorter regimens and newer regimens which are orally for drug resistant TB, and patient-centric care. They have expanded the DOT strategy using IT-enabled adherence support, call centers, and comorbidity management. And to reduce the out-of-pocket expenditure, financial incentive benefit. So these are the pillars, and we expect sustained treatment success rate of more than 90%, and injection-free treatment regimens, scale of newer drug regimens like bedaquiline, delamanide, and also introduction of ASHAs and community volunteers as DROT providers. The direct benefit transfer scheme is important for enabling the patients to adhere to the. So honorarium to treatment supporters for patients, adherence, ADR monitoring and counseling at a rate of 1,000 to 5,000 rupees, and patient support to tribal TB patients at a rate of rupees 750, nutritional support to all TB patients, financial support of rupees 500 per month, and incentives to private providers rupees 500 for notification and 500 for reporting of treatment outcomes, and incentives to informants, and also like airborne infection control measures are being pilot tested and expanded, and strengthening of the contact investigation, preventive treatment in high-risk groups, management of latent TB infection, addressing determinants of diseases and comorbidities. So these are the interventions under the prevent strategy, and also like ensuring sustaining the COVID appropriate behavior, hand sanitation, using masks, ensuring social distancing. So all this would also facilitate the prevention of TB transmission. And community mobilization and people's movement is one of the important activities under the prevent strategy. Moving to the build strategy, so there are various activities. So information, education, communication, capacity building, human resource development, multi-sectoral collaboration, digital interventions, surveillance, procurement and supply chain management. And now we had moved to case-based surveillance, and also like we have Nikshay Poshan Yojana, where they do the direct benefit transfer of rupees more than 1,200 crores for the last few years, and multi-sectoral engagement, because like TB could be present in any person, and so different levels of collaboration and coordination with multiple sectors are required. So TB care services in healthcare infrastructure is strengthened, and infection prevention and address determinants, prevention and care at workplace, socioeconomic and support and empowerment of various line ministries. And so this is done in collaboration with labor and employment, Panchayat Raj institution, postal services, home affairs, defense. So this is to ensure that the social barriers and the multi-sectoral approach is done to ensure that the scale up of services is happening to a wider level. So these are interministerial coordination between various line ministries of Ayush, Railways, Defense, and Labor Employment. Community engagement is one of the important strategies that is part of the build component. Here, the approach is that we transform the TB survivors to TB champions, and they build the capacity of the local population. And here they are exposed to capacity building and mentoring by the program, and engagement of existing community groups like Panchayat Raj institution, self-help group, village health and sanitation committee, youth clubs. They are given the options for grievance redressal mechanism and involvement of community representatives in different forums. And also like there is presence of TB forums at all stakeholders, including the community, to voice their views. Because unless we are able to engage with the community, making a major dent is very challenging. To provide help for counseling, treatment adherence, grievance redressal, to clarify Nikshay Poshan Yojana. And this has a pan-India coverage and 14 languages. And this provides services for citizens, patients, and providers. So India has committed to end TB by 2025, 5 years ahead of the global SDG target. Prime Minister of India launched TB Free India campaign at Delhi NTB Summit on 13th March 2018. The campaign calls for a social movement focused on patient-centric and holistic care driven by integrated actions for TB Free India. See that the reduction of compared to 2015 of TB incidence is 80% compared to 2015, and zero catastrophic cost due to TB. So these are the targets India has set, and to ensure that the desired decline in global TB incidence rate and also the Indian TB incidence rates are to be achieved, we need to use the introduction of newer tools, optimize the existing tools, and we need to invest more in research. So here the graph shows that over a time period on the x-axis, and on y-axis we could see the rate per lakh population. Here we could see that the red line shows the current global trend of 1.5% to 2% per year decline. As what is expected is 10% per year by 2025 if we have to reach the targets. And if we have so achieving the bending of the curve or increasing the decline rate per year for incidence of TB, we need to invest more in research to ensure that we find new vaccines, new drugs, new treatment regimens for treatment of active TB and latent TB and point of care test. So strength research is one of the major activities apart from community engagement, because only if we are able to invest in the, we will be able to get point of care diagnostic test, which will be easy for the people to diagnose at the peripheral levels, and shorter regimens which would improve the adherence, compliance and treatment outcome, and shorter regimens for latent TB infection. We will not meet our goals and end the TB epidemic without new and more effective vaccines, new TB vaccines, drugs with shorter regimens for treatment, improved point of care diagnostics. So these are required for ending the TB in India. So this is the campaign to rally energy, political will and funding to end TB. So what does it mean? So we plan to have a once a month or a 1 weekly treatment regimen for TB prevention, and 4-month treatment regimen for drug sensitive TB, and 6 months treatment regimen for drug resistant TB by the end of 2024. So this would enable us to make a faster dent in the curve of TB. Let's join hands together to end TB. Thank you.
Thank you, Dr. Sriram, for the wonderful talk, and you have summarized all the data and the current burden, especially in India, here you have summarized. So we have a few questions here from the audience. One is, as you talked about in the last part of your talk, the TB vaccine. So, I mean, TB vaccine status and the shorter regimen of the drug, because I mean, I understand a lot of funds have been given to TB research globally. So here, one of the audience participants wants to know what is the current status of TB vaccine, when this vaccine will come in the market, because you know that despite having a lot of effort towards and TB, still you have mentioned that between notification and estimation of the cases, still 4 lakhs patients gap is still there. So hardly 2 years to achieve this goal. So I think one of the effective tool would be the vaccine. So this question is, when TB vaccine will come into the market?
Thank you, sir. The point is like vaccine trials are currently happening. So in India also, like there are 2 to 3 phase 3 vaccine trials which are happening. So one of the vaccine trials that is happening is comparison of VPM 1002 with Immunovac and the placebo. So that is a recombinant BCG vaccine which is being tested in the country. And also like the challenge with identifying a vaccine for TB is the presence or identification of correlates of protection. And because of the wider markers for the TB immunology, there are very few indicators which are there to show that these are correlates of protection for TB vaccine. And also like BCG is one of the time-tested vaccine which is identified as safe and which is given to children and newborn. So here India is now planning to do a trial comparing the BCG vaccine in adults, because the BCG vaccine given in the newborn is able to prevent only severe forms of childhood tuberculosis. Apart from that, we the usefulness of those vaccine in vulnerable population. So we have done Chengalpat, seen that the BCG is able to protect only severe forms of childhood tuberculosis, whereas in adults it did not show any protection. The recent analysis of BCG Chengalpat showed that the revaccination of BCG vaccine could provide some direction of protection which needs to be further evaluated. So this study, which is currently being planned in the country, is one of the biggest vaccine trials where we are going to give BCG vaccination to vulnerable population of smokers, diabetes, malnourished, recurrent TB patients who have completed treatment, and those who are elderly, And so we are trying to compare if this vaccine BCG, when it is given in vulnerable population, is it able to protect TB in those vulnerable group of people. So that is the current situation. And also like recently, like MTB vac, which is the one of the vaccines from the Mycobacterium tuberculosis is also planned to be tested because majority of the TB vaccines are either from M. bovis, and only a few of them are from Mycobacterium tuberculosis strain. So MTB vac is one of such vaccines which is planned to be tested in India. So it would take at least a few more years for the new TB vaccines to be coming to the market. But currently, like India is planning to do a study to understand the effectiveness of BCG in the adult vulnerable population.
Similar, question, which is also very important. Shorter regimen of the current drugs. Is there any new development in this area also?
Yeah. So here there are studies which have been done both in India and elsewhere to see the shortening of treatment regimens for both drug sensitive and drug resistant TB. Like in NIRT also we have done the shorter regimen of moxifloxacin based treatment for TB, drug sensitive TB, and so they had also shown protection, and so they are now being tested in the cluster randomized trial in the field conditions with 4 months regimen. And like also like there are a refer short study which has been tested in other countries where they have given 4 months of high dose rifampicin regimens, but they were not able to demonstrate non-inferiority to the standard of care. And also like there are other trials of shortening of the drugs for drug resistant TB. Like in India, we did the Beat TB trial where 6 months of bedaquiline and delaminate containing regimen was given, and that was found to be efficacious and producing favorable outcome among 91% of the participants.
Okay, and one of the very basic question from one of the PhD student: how to minimize the MDR and XDR cases of TB?
So how to minimize MDR and XDR TB patients? First we have to ensure that patients are diagnosed early and started on treatment, because if a patient who is drug resistant TB is not diagnosed early and started on treatment, he would be transmitting MDR TB or XDR TB. So that is why we are recommending universal drug susceptibility testing, where they should be tested for rifampicin isoniazid. And once they are started on treatment for either drug sensitive or drug resistant TB, they should ensure that adherence is monitored and they ensure good compliance. So if we are able to monitor these two important indicators, we would be able to reduce the transmission of MDR and XDR TB. And also doing contact tracing of the MDR and XDR TB patients is another important aspect to see how these patients are diagnosed early and start on treatment.
Dr. Manjurai has
Yes, I'm here again. I mean, I was listening throughout the lecture, and thank you, Dr. Sriram, for giving such a beautiful overview of the tuberculosis as a disease, beginning from how it starts and the treatment part and all the developments which have happened. And NIRT is at the core of the whatever new developments are taking place in terms of a diagnostic or research. I was just a little curious if you can inform us what is the, in nutshell, what are the numbers we are looking at for tuberculosis in India as an outcome of your study. My second question is, in your last slide, now this is a little disconnected, but I see that all infectious diseases like even malaria or lymphatic filariasis, they are facing similar challenges as TB is. But in one of your slides, and TB is, I think, a pioneer that you are taking all ministries together. There is a lot of involvement of multiple stakeholders, including private sector, and they have been able to contribute in the public health program, which we are still, see it in a nascent stage, at least for malaria. And for LF, the private sector is involved more or less in the implementation of the program, but not in reality, in true sense, they are hand in glove. So my first question is, in the nutshell, what are your research findings about the burden study? Number two is, because you are integrally involved in the national program also, how intersectoral convergence or other sectors can be pulled in for implementing such large programs for the country, because we are finding it difficult in other diseases.
Yes, madam. Thank you. To summarize regarding the TB prevalence survey, the important findings of this study showed that the prevalence of microbiologically confirmed pulmonary TB in India is 316 per lakh population, and the prevalence to notification ratio, which is an important indicator which tells for every prevalent case how many cases are missed, and that number is 2.84, which means that for every case we are missing around 3 patients in the community. So that is what is reflected as the gap between the estimated TB patients and the notified TB patients. So we have to strengthen that. So how do we strengthen that? So we need to know what are the group of people who are vulnerable for getting TB. So we have to focus on those group of people and then identify TB disease in them yearly. So that is where population attributable fractions come into place. So based on the National TB Prevalence Survey, we were able to estimate the population attributable fractions for TB in India, and that is where malnutrition, self-reported diabetes, self-reported smoking, and then recurrent TB, and then elderly people. So they are contributing to more than 80% of the TB patients diagnosed in the country. So if we are able to screen these 6 group of population, we would be able to reach around 80% of the TB patients in the country. So this is to be prioritized, and that is where we also recommend based on this study, like wherever there is a high prevalence to notification ratio, there should be strengthening of the case finding, and we should also shift towards molecular test and chest x-rays for diagnosis of TB. The other important finding which I mentioned also was healthcare seeking behavior, because only 36% seek care among those who are symptomatic. The 64% do not seek care. So strengthening the IEC and advocacy communication to the people so that they become aware of the symptoms, they become aware of the healthcare facilities, they become aware of the decentralized facilities at the health and wellness center is more important, so that they are able to seek care and get themselves diagnosed and treated. So that is the major points from the survey. And also, like we were able to see that this multi-sectoral coordination is because of the political commitment at the higher level. So this starts at that level. So the Central TB Division and the Ministry of Health and Family Welfare, they are able to establish this linkages. And if the other disease conditions is also considered as a priority for elimination, so they would also be able to mobilize that support from other line ministries and do a multi-sectoral coordination.
Thank you, Sir Dr. Sriram. I think you have hit the nail. The last sentence is like prioritizing the disease for elimination and political commitment from the highest level. That is the key factors here for bringing everybody together on the same table. Thank you, Dr. Sriram, for this lovely talk. Over to you, Sachin.
So,
thank you everyone for patiently listening.
In interest of time, I'll take only the last question from here. This is about how to manage the migrant population, borderline population, and deduplication. Second is we have NATT upfront now, but the supply and demand mismatch is here. So these are the questions I can see. One, first for the how to manage the migrant population.
So migrant population is one of the vulnerable or high-risk group of people who are susceptible to get, because they move from their original place and stay in another place for their work. So they might be living in a hostile environment, so the environmental conditions might not be appropriate. Just a place where more people are living. So all this pose a risk for TB. So in active case finding, when the healthcare workers map the population, so they should be able to identify if they are migrants, how many of them are there, whether they are screened for TB or not. If that is able to be done, we could be able to increase the case finding in migrant population. So identification and mapping of the location of the migrant population is the first key point. Next, once they are mapped, they should be able to conduct active case finding in them or screening for those migrant population. The next thing is if the person is diagnosed as TB and because he is a migrant, he gets diagnosed in one place or treated in another place, and he should be able to get the treatment adherence, support, and drug supply living or working. So for that, coordination between different districts, or if it is between countries, other districts of the countries is important. So understanding of the requirements, understanding of the location where migrants are there, and understanding how they could be offered the screening test is important to identify the TB early in the migrants and providing treatment to them early. Next question is on upfront NAT. So NAT, now we have both CBNAT from Cepheid and TrueNAT, and more tests are in pipeline. So here now, because state and the center's coordination, so certain situation the center provides the supply, certain situation the state is able to do the procurement. In certain states where the procurement system is strong, they are able to do the mobilization of funds and do the procurement. So it is mostly understanding what is the requirement as a forecast, and then managing the supply chain based on the availability either from the state or center, which needs to be prioritized, and that is mostly management issues which could be done through coordination.
Final one is the word, what are the conditions which trigger relapse of TB after cure?
Yeah, so recurrence of TB is the common term which could relapse is the same bacilli re-emerging of time, even though they have completed treatment and called cure. So that could be because they might not have adhered to the sufficient because of any behavior like smoking or alcoholism, or because of administration of other drugs for other conditions. And also, like other reason is the potency of the regimen which is being prescribed. So if the regimen is not appropriately prescribed, then the chances of relapse could happen. And reinfection could happen if there is a person who is living in a high burden area. The risk of exposure to bacilli is more, and he could get reinfection. So these are the factors. Like mostly it is the adherence, bioavailability, the potency of the regimen, and the comorbid conditions and behaviors.
Okay, thank you very much. And as I said, in interest of time, we need to conclude this talk now. And from entire MERA-India team and NMR, I thank you, Dr. Sriram and Dr. Padmapriya, and NIRT and the whole ICMR system. Thank you very much for the complete overview you have given through your talk. And I thank you all the audience for their patience also. Thank you very much.